We're going to talk about how to manage an agitated patient. How many of you have protocols that allow you to sedate a patient that's agitated and combative or in excited delirium? Anybody? And y'all can comment if you have that ability. Does anybody? Walt says he has one, yeah. Okay, good. Versed based? Okay, is that in Ohio?
No, that's in down in Kentucky.
Oh, okay. Okay, cool. What about ketamine? Is anyone using ketamine? Well,
Crickets.
um, I'm sure some of you are. There's quite a few of you on here. And maybe if you're interested in using ketamine, this might be the talk for you. So looks like we've got some using Versed. Maybe some of you are using ketamine or interested in ketamine. And I think Versed is a good agent. And I think there is definitely a role for Versed in managing an agitated and violent patient. But there is a problem with ketamine. And that problem is that people are coming for it. People are going to come for your ketamine. They might not come for your ketamine, but they're coming from somebody's, I'm sure, right? You know, it's happening in Aurora, Colorado. And I was recently on Facebook on talking to a non-medical friend, and they said the ketamine killed that person, you know, both of the people in Aurora. And of course, I had to rebut and just say that's not really true. But the fact of the matter is that ketamine, like fentanyl or anything, you know, once the media gets a hold of it and they give their interpretation of it, and then they start reporting half truths, then everybody thinks that it's the drug that's killing the person. And I just don't think that's true. But even if it's not true, it's still our responsibility, right? It's the paramedic's responsibility that's given the medication to use it responsibly, right? To give it when it's actually indicated, to give the right dose, to give it the right route. It's the paramedic's responsibility to properly resuscitate that patient, even after they give the ketamine. Now, it's an administrator's responsibility, and I'm lucky in that I am both a provider and an administrator. I hop on the truck every chance I get. Anytime we're short, you know, they say, "Hey, you want to work?" Of course I do, right? So it's as an administrator's responsibility. It's my responsibility that we provide good quality assurance. We write protocols that are evidence based. We provide, you know, we conduct quality assurance. We review the charts. We know when it's working and when it's not working, right? And we make modifications as we see fit, based on our chart review and our audit. And, you know, if you are an administrator and you're not doing this, or you're not, whoever is under you is not adequately performing their quality assurance functions, then they could claim, you know, administrative negligence if there is a bad outcome. Unfortunately, we try to build a culture where we're not necessarily um, basing our review, our remediation, our post-event actions based on the outcome, right? Because we know that sometimes patients have bad outcomes no matter what we do. But we try to build a culture here where we can not punitively, but openly and with full transparency discuss any issues, any mistakes, any mishaps that we might have, and we learn from it. I just got off a CQI meeting call where we reviewed 2 charts, and that's just the culture that you have to build at your agency. And frankly, if you're not performing these sorts of functions, if you're not doing detailed post-event reviews and you're not doing quality assurance, then maybe you shouldn't be given ketamine or anything like that. So when we talk about how we should manage the combative and the agitated patient, well, in my opinion, the answer is it depends, right? If you have a sole agent that you give for an agitated and combative patient, I think that you might be doing it wrong. Now, I think you could probably choose a sole agent, right, and make it work. But there could be some adverse, consequences or outcomes from that. So there's a spectrum of agitated or agitation. There is the patient that is agitated, but cooperative, right? I liken this to someone that is just a little anxious, right? But they are still allowing you to treat them. They're still allowing you to perform your job, your function. This person isn't that difficult. Then there's the person that is disruptive, but they're not dangerous, right? They might be annoying in that you can't actually treat them. They're pulling at their IVs, they're pulling at their NG tube, they're pulling at their oxygen, they keep pulling this off, but they're incoherent, right? They're not completely lucid, and you can't effectively treat this person. And then on the far end of the spectrum, there is the agitated, not cooperative, and dangerous person. This is the patient that's going to harm or hurt either themselves or you, and you have to manage them quickly and aggressively. Now, how do we treat each of these patients? Well, the agitated but cooperative patient doesn't, in my opinion, in the pre-hospital field, require any anxiolysis in terms of medication. I think that all we have to do with them is remain calm, don't be condescending, be nice, provide some comfort, don't be aggressive with them, right? And generally, they'll be fine if you dim the lights a little bit and transport them nice and easy to the hospital. The next patient may or may not require an intervention, right? So they might be disruptive. They might be withdrawing at your efforts to treat them if you need to treat them, okay? But if you do need to treat them, then I think that the medication of choice is some kind of benzodiazepine. Our default is Versed, just because it's something we carry, it's something that we're familiar with. You can replace this with whatever you have on your ambulance. For the patient that is agitated, combative, that's going to hurt themselves or you, I think that the only way and the best way is, I want to redact my statement on saying the only way. It's not the only way. There are multiple ways, but I think the best way to manage this person is the rapid administration of ketamine. This is not the person that we want to titrate a benzodiazepine to achieve the level of sedation that we want. This is the person that we want rapid sedation. We want it within seconds to minutes, and we want the first dose that we give them to provide that level of sedation that we're trying to achieve. Okay, the person that's disruptive without danger, we have the luxury of being able to titrate something to provide the level of sedation we need. In all cases, there's a good chance that you might have to restrain the person. And I'm sure that you have a restraint protocol or a policy. But that still doesn't mean that we're doing it right. There are many different ways and forms in which you can restrain a person. And if you're using 4-point restraints, there's a right way and there's a wrong way. And typically we don't do it the right way. And I want to draw your focus to this image and look at the arm restraints. One arm's up, one arm's down. Why is that? And it's not typically the way we do that, right? We typically have both arms down. That's usually our default. They put one arm up because it makes it more difficult for the patient to raise up. If both arms are down, then they can easily raise their torso off of the stretcher. When it comes to the legs, I think it's probably okay to do them on to secure the restraints on each side of the gurney, but it's probably better to crisscross the restraints because it's easier to apply force when you kick if you're doing it lateral, if you're doing it out to your side as opposed to trying to go medial and kick that way. You can also use the straps on the stretcher along the chest as long as it doesn't restrict respirations. So this is a simple flow chart, and I'm a simple person, and I think about these things until it makes sense to me, and typically if it makes sense to me, it'll usually make sense to most other people. There's one question you have to ask. Can you effectively manage this person in their current state? If yes, we probably don't need to be giving anything. I used to think that that wasn't the case, but my mind has changed over the years. If you can manage them in their current state, then we probably don't need to give anything. Maybe if they're in pain, give them something for pain. But if not, if you can't effectively manage them, then there's one more question you have to ask. Are they going to hurt themselves or are they going to hurt you? If they're not going to hurt themselves or you immediately, then give them a slug of Versed and see how it works. If they are going to hurt themselves or you, then you give ketamine. Now, one question we always ask when managing these patients is it excited delirium, right? Is this a patient with a severe hypermetabolic syndrome? In a few words, are they going to struggle to death, right? This is like an athlete that is, playing football and they just keep going and their body doesn't have a way of telling them that they need to stop, right? So is it that person? Because if it is that person, it sort of changes the way we need to manage them. And I think that we should manage them irrespective of if they're going to hurt themselves or you, because if they are truly in excited delirium, they have a good chance of dying. These patients tend to rapidly progress from alive to dead in a matter of minutes. The best thing that we have to intervene, and time is of the essence. This is not something we should be standing around and twiddling our thumbs on, right? We have to intervene quickly. The way that we, sorry, our dispatcher's talking, distracting me. The way that we intervene and the way that we halt this rapid progression to death is with the rapid administration of ketamine. These patients have, and this is what I refer to as my own personal excited delirium triad, right? They have profound hyperthermia, they have severe metabolic acidosis, and they have severe rhabdomyolysis. This is all exacerbated by improper positioning, improper restraint, and their continued struggle. So ketamine in a way is therapeutic in that it stops all of that. If you have an excited delirium protocol, but you don't have an option for managing patients who need something a little less aggressive than ketamine, something like Versed, then I think that your providers are going to be sometimes stuck between a rock and a hard place. They're not going to be able to adequately manage a patient who is agitated but not combative and not in excited delirium. And their default might be to give the ketamine dose, the dissociative dose for excited delirium because they have nothing better. But I also believe that there are times when we misunderstand, or we don't fully understand exactly what excited delirium is. And we tend to call we want to call every patient that's agitated, that's combative, that is resisting our efforts to treat them, excited delirium. And that's just not the case. I'm going to share a video with you that demonstrates what excited delirium looks like. Hang on a second. I don't think the sound's coming through.
Elm, where neighbors got an eyeful but also applauded police for their efforts. Jeff?
Nadine, like some of our police activities, this particular standoff went long enough for neighbors to record some of it on their cell phones. From his vantage point, Benjamin Blazevich, he wasn't sure what was about to happen, so he had his camera rolling just in case.
I'm leaving.
It was the sound of this man's screams that brought Benjamin Blazevich and his friend Nick to the end of this Broadway Avenue alley.
Well, at first it was kind of a shock when I walk around the corner and there's a naked dude screaming a bunch of random stuff.
Because of recent critical incident training, Sergeant Tony Giannetto knew the man was suffering from excited delirium and first called for paramedics.
And then we noticed all the cops started showing up. Yeah, and then he's flopping in the street doing his naked thing.
By then, the sergeant already told dispatchers he would need at least 4 officers to contain but not crowd their subject.
We recognize that excited delirium is a medical issue, and it is not as if we were chasing a fleeing bank robber or some crime in progress. So our main concern is to make sure the person stays safe and that
Okay, am I still on here? I'm going to take that as a yes. That video demonstrates classic signs of excited delirium. And a lot of people will say, well, how do you diagnose or determine that it's excited delirium? And there's not one simple definition. I think that we have to address it from more of a...
they don't present a danger to anybody.
The scene.
Nobody has saying
successfully, it doesn't...
And on.
So we can look at features in the history, features from the scene, clinical assessment features, and features when we're physically in contact with that person. And this is a busy slide. You can take a picture of it if you want. It'll be there, I think, when Walt uploads these to YouTube. But there is a better way to summarize this, is the frequency at which these features are present. You know that these patients are pain tolerant, right? They don't feel pain the same way that you and I feel pain. They're tachypnic, they're sweaty, they're agitated, they're hyperthermic, they're not compliant, they don't get tired, and they usually present with unusual strength. It usually takes multiple people to hold them down. Now, if we have a person like this, how do we manage them? Well, we manage them with ketamine. But so imagine that you had Chuck Norris that was having excited delirium, and he was just kicking everyone's tail. Well, we know that we want to manage them by rapid administration of ketamine. So we give ketamine, and then we all start cheering, right? We start applauding because we have just taken out Chuck Norris, and he's no longer a threat. But this is not the time for celebration, because although we have given ketamine, we have still we have somewhat reduced the progression to death by administering ketamine. That person still has all of these other clinical features present, the profound hyperthermia, the metabolic acidosis, and the rhabdomyolysis. So we must continue the damn resuscitation. This is not the time to, slap hands, to bump fists, to congratulate everybody on sedating Chuck Norris. This is the time that we must get off our butts and continue the resuscitation. Now, I'm sure you've heard this before, and it seems to be in vogue at certain times of the years. A lot of people like to say, don't just do something, stand there. And I'm telling you, for a patient that you have just given a large dose of ketamine to, or Versed, or any sedative or anxiolytic, this is not the time to just stand there and think about your differentials. Once you have, in essence, disconnected this patient's brain from the rest of their body, you still have to manage their care. You still have to treat them. So in this case, this is when I want my paramedics to not be just standing there, and I want them to actually do something. Here is another example of, this is a video, this is police footage from Aurora, Colorado. And I want you to think about, was the management appropriate? Did the patient actually need ketamine? And was the management after the administration of ketamine appropriate as well?
Drive your knuckles right there. You don't have to put pressure until he moves. All right. So we got 500 ketamine. Yep. Awesome. Thank you. Station 523. Okay. All right. Just drive it right behind his ear if he fights. All right. We'll give that a minute or two, see if that works, and once it is, we'll go ahead, if you guys are okay with it, we'll uncuff him, we'll go up with the right arm, down with the left, and we'll just restrain everything. We'll give that a minute or two.
All right. Hey, Woodyard, Rosie, here in a minute, once this medicine kicks in, we're going to uncuff him, put him on the bed, and then we're going to restrain him, soft point him to the bed.
All right, no, you're okay, I got it.
You guys have any extra gloves on you?
My back pouch right here, dude.
That's right here for you. Okay.
They're extra large, just so everybody can fit them. But
just to fill you in, lose contact if we're walking down the street wearing like a wrestling mask or something like that. So I call these guys to get him down and he's an injury. No pain compliance, they're completely good. That's gone. It's limits, we're still fighting what we got here. He's super diabetic, he's tachycardic. So I was excited to learn, and that's why we gave him 5 of ketamine. We had no idea as far as the allergy. So we're going to give him maybe another minute. It looks like it's starting to kick in.
Yeah, he's snoring.
Ready. We'll go ahead and uncuff and take him up to you. Is he in custody or?
Yeah.
I'm sure he will be.
I'm sure he will be, man.
Okay, yeah. That's fine. Just like the hospital staff know.
If he's not already.
All right. How's he? Does he seem a little?
Yep.
Okay. We'll go ahead and get him on his side, and we'll just uncuff him.
Let's get him on the gurney first.
Okay.
If we can.
Okay. So you guys want to do that? Careful.
Yeah,
Careful.
he's definitely.
All right.
Throw up on you guys.
So we'll put an Untitled canyon on both.
Give him some light.
So we can have that ready too.
Do the right one first.
Hey, would you?
Yeah.
Somebody grab this.
I got it.
You guys got that one? Yeah.
All right. So from the 1,000-foot view, looking from the blunt end, retrospectively at this case, it's very difficult to know, one, was this excited delirium? From my perspective, it didn't appear to be excited delirium. And from what I could tell, when they got on scene, the patient was no longer really conversing, was no longer agitated, wasn't resisting. Now, with all that, setting all that aside, if this was a person that you decided needed ketamine, once you administer the ketamine, it's time to do something, right? Don't just throw them on the stretcher and don't just load them in the ambulance. Actually, while you're drawing up the ketamine, you should be gathering and putting together all of your other resuscitation equipment. This is a person that I want to go immediately on the monitor, right? I want them tethered to this monitor to keep them from floating away. I want suction turned on, ready to go. And I want a BVM out, assembled, and with waveform capnography set up so that we can monitor our ventilations. And as soon as feasibly possible, I want the BVM on the patient, okay? Even if you're not sure if the patient needs the BVM, I want the BVM on the patient. I want their ventilations assisted, and I want Untitled monitored. I don't want there to be any police footage from anyone in my agency or any other agency of them administering ketamine and not having the resuscitation equipment applied immediately following that. Because even if the patient is no longer agitated, is no longer combative, we still have to resuscitate them because there's a whole list of other things that we haven't fixed. We may have slowed the progression down, but we still have to resuscitate that person. And not only that, these patients are extremely likely to die, right? And once they reach that period of tranquility where they appear to give up, they are no longer fighting you. Think of it as the child that's no longer crying, right? We like it when kids cry, don't we? When the patient quits struggling, that is not a good sign. That is a sign that death is imminent and we have to intervene quickly. So we usually say that ketamine is the best drug for these patients. And I think that is. But I think that we misunderstand some things about ketamine, right? And a lot of people seem to think that ketamine cannot cause respiratory depression, that it will not lower the blood pressure. And that's not necessarily true. Peter Antevi shared this post, and you can see here where he talks about the key benefits of ketamine. He modified, or he changed this a little bit, but initially when he first posted, he posted that it does not depress the respiratory system. Anything that we give, any sedative, any analgesic, can depress the respiratory system. Now, ketamine is much less likely to than any other agent, right? It generally maintains the respiratory system. It generally doesn't lead to hypotension, but there's something about ketamine that a lot of people aren't aware of. You have to realize that ketamine requires the patient's own endogenous catecholamines to be present, to be vibrant. And in a patient that has just struggled for however long, resisting restraint, resisting arrest, being position prone, is possibly exhausting their catecholamines. And the administration of ketamine, although the best agent and the ideal agent can cause these things, it's even in the drug card for ketamine. It can cause hypotension, bradycardia have been observed, arrhythmia has also occurred. Severe depression of respiration or apnea may occur following rapid intravenous administration. Ketamine is the preferred agent. And when we review most of our excited delirium cases where ketamine was administered, we usually transport them to the ER, we monitor end-tidal CO2, apply oxygen, put them on the cardiac monitor. There have been no issues. And usually they're discharged from the ER once the ketamine wears off. That's how safe it is. If you have ketamine, and if you give ketamine for anything else, if you give it for pain, the dosing can get a little wonky. And I have seen, I personally have had some issues with this. So we've got to understand the ketamine brain continuum, which means that unlike other medications, unlike fentanyl or morphine or Versed, generally you give it, you give more, you get more of a response, right? And then at some point you're going to hit a ceiling. Well, that's not really the case with ketamine. There is the dose response curve is a little different, right? It's not your typical dose response curve. At small doses or low doses, around 0.2 per kg IV or 1 per kg IM, you get an analgesic effect. If you give any more than that, but you don't give enough to fully dissociate them, then you get in the recreational phase, which you get these weird psychoperceptual effects. This is like no man's land. This is not where we want the patient to be. So we either need a low dose or a very high dose to fully disassociate them. And the dissociative dose is anything over 4 per kg IM or 1 per kg IV. This is the Richmond Agitation and Sedation Scale. If you ever have to call medical control and you need a way to use common terminology that they would hopefully understand, that would adequately describe how the patient is behaving, then this is what you should use. And we have this laminated and placarded in a little checklist in our ambulance. Here's our protocol. I'll let you look at that. Now, this is not our current protocol. This is one that we have submitted. In the past, we have just had ketamine as an option for either pain or excited delirium, but we haven't had an option for the patient that's somewhere in between, that doesn't need to be fully dissociated. And we went with Versed for this. Because I realized that maybe we're giving ketamine for excited delirium too often because there's not a better choice. So we just went with Versed. You could go with whatever, but it's something that we carry. It's something that we're familiar with. We were given ketamine 4 per kg IM instead of 5 per kg, as it says here. We've changed that, and hopefully it'll get approved, but we changed that because we were seeing patients going into the recreational range. We were seeing a lot of psychoperceptual effects shortly after the administration of ketamine, and they didn't have the option to re-administer ketamine to push them into the dissociated range. So it may have been a problem with how we were calculating the dose. Some protocols may have a set range. If they're this weight to this weight, then you give this dose. If they're this weight to this weight, you give this dose. That's how our protocol was. And I saw that we were occasionally underdosing the patient. And we were dosing based on actual body weight and not ideal body weight. And ideal body weight is how ketamine should be dosed. And what we're likely going to be doing in the near future is getting measuring tapes and having an ideal body weight chart that's readily available, so that if they give a weight-based medication, they simply pull out the tape, measure head to heel, and then reference the chart for their ideal body weight. And when we decided to switch from 4 to 5 mg per kg, we actually consulted a toxicologist and a doctor of pharmacy to get their input. And they both recommended switching from 4 to 5 mg per kg. Now, I want to provide you, before I wrap this up, I want to provide you with some pearls for the IM administration of ketamine. When you're giving IM medication, use the Z-track method. And some of you may do this already. It's when you pull the skin. You don't pull it on both sides, but you pull it on one side, and you displace the tissue underneath it. That way, once you give the IM medication, you pull out the needle, the skin returns to normal. So that medication is then better trapped in the intramuscular space. Now, a question that we had to look into was, how much can you administer intramuscularly? Because you can carry different concentrations of ketamine. You can carry, and Versed. This might be an issue with Versed depending on your concentration. If it's not very concentrated and we want to give 500 milligrams of ketamine, well, we might need to give 10 or more mLs. And the question we asked was, how much volume can we administer IM? And when you look at most of the references, they say max of 2, max of 3. If it's the dorsal gluteal region, maybe max of 5. But there is literature out there saying that you can give 30, depending on the medication, you can give up to 30 mLs. And they did this with phosphentolin. And there were no adverse effects. So I think if you use the right technique for administering IM medications, and if you use the right technique, then you can give a larger volume than is typically recommended without any adverse effects. And I think that this is probably safer than trying to get a needle on each side or giving it on one side, then giving it on the other side. It's probably best if you're given IM medications for sedation to just have to worry about giving it on one side. And that's all I have, and I will take any questions or any thoughts.
Awesome, Floyd. Thank you so much. I may have spaced for a second there, but so 30 mLs single site IM injection, huh?
Yeah, there have been a study, and there's multiple studies. This isn't the only one, but there's a bunch of them looking at large IM doses, and you can just Google large intramuscular administration or something like that. You'll find all the studies.
Cannot imagine. Whew.
Yeah, that's a little excessive, but
if nothing else, you're not going to fight back anymore just because you don't want that to happen again. Jeez.
Yeah, and give it slowly if you're giving it IM. Don't just jam it all in, because that could cause a lot of pain.
Yeah. Awesome. Yeah, super informative talk and super timely. If there are any other questions or anything, I've been just kind of looking at the chat, not too much there, I think, now. But yeah, so you guys are outright using ketamine for your agitated patients, or for your excited delirium patients, but still using the Versed for the just kind of wacky guys otherwise, I guess, huh? That's cool.
Yeah, that's what we're wanting to go to. Like, if I want to keep it simple so that they don't have to think much about it, but if they're going to hurt us or themselves, whether they have excited delirium or no excited delirium, give ketamine. If not, they can consider Versed and titrate, because you have time to titrate at that point.
Cool. Have you all actually got like a high number of patients or anything? Like, I can't imagine. Well, I guess I could see kind of Jessamine County getting rowdy on a Friday night or something like that.
You know, we've and one of the major reasons we're going to this is because we've called med control a lot for patients that aren't in excited delirium. And we had an issue where a provider got injured while someone was on the phone with medical control while they were waiting for orders for a patient that wasn't in excited delirium. They were just trying to get orders for Versed, and one of our providers got injured while they were trying to hold him down.
Gotcha. Yeah, it's hard too. Like, you know, everybody thinks, oh my God, these people got this drug. But when you really think about it, these guys, this is all high risk stuff. Like, you could get the drug and get kind of, you know, take the little bit of risk from that. But the other option is that the police are going to beat the crap out of you, trying to tie you down to a bed, and then you fight all the way there and, you know, hurt other people in the meantime. So,
and you're probably going to die, especially then.
Yeah. Yeah, it's like blaming that. Not that again, you're absolutely right. Like, totally there. You can't just stop resuscitating once you get the guy down. But yeah, it sort of seems to me like blaming aspirin for the high rate of mortality after an MI. You know, like it's not really the aspirin that did it. The aspirin was just kind of there at the time. So
Yeah, and that's
But
the frustrating part. That person had a high risk of death to begin with, even before they gave the ketamine, most likely. And there are a lot of other contributing factors. And I think, something else I wanted to say that, once we get on scene, it's our scene, okay? The way that you position that patient, it should be your scene, right? You call the shots. We still need law enforcement there. We need everybody else there to help us. But you know what? Step up. If the patient's being restrained face down, have them roll them over if at all possible. And if you don't have that relationship with your law enforcement officers, then you need to start building that so that, they need to understand that, hey, we don't fully understand everything that they do. We're not going to exactly tell them how to do their job. But when we get on scene and we start treating a patient, we need them to, not necessarily step aside, but take some advice from us and how to manage the patient.